Man, would you look at that face? Yeah, shameless plug. That's my baby. Anyway, let's get back on track. So we're going to talk about immune deficiencies. So we've talked about the different types of cells. When you look at the types, you need to be familiar with the B cells, the T cells. You need to know what the antibodies do, what the complement does. If you know those, you know what they primarily attack. If you have a deficiency in that structure, then you know what you're more susceptible to. Like, for instance, if you know that bacteria or encapsulated bacteria are easily attacked by antibodies, if you have a deficiency in B cells and you don't make antibodies, you're going to see more encapsulated bacteria infections. And I'll go through and explain some of these as we go. But immune deficiencies are just basically a failure of the immune mechanisms of self-defense. So whichever one it is, it can be combined, it can be one individual, it can be, whatever. So there are two major groups. You've got the primary, which are congenital, which means that you're born with it, or you have secondary, which means you've acquired it. And so HIV is a good example of secondary. People get it as adults, out in, I guess you don't have to have it as an adult, but people get it out in the real world out there. Where the primaries, you're born with this defect or this problem. So some examples when you look at the names like hypogammaglobulinemia means a decreased immunoglobulins in the blood. A gamma means without globulins. SCID, severe combined immunodeficiency. So it's telling you it's a combination of the immune factors. Here are some of the common primary immunodeficiencies, and we're going to go through these as we flip the slides. There are some things I really want you to note as we're going through this, though. When you're looking at the immunodeficiencies, number one is that they're going to get more severe infections than the average person because they don't have the immune system to fight it. They get more frequent infections, so they get recurrent infections, like once a month or once every other month, very frequent. They get more frequent cancers, or they have more risk for cancer, because remember, your immune cells attack cancer cells and destroy them. They get more autoimmune disorders. So there are a lot of things that happen to these people. Another key to think about is, yeah, they get more like recurrence of infections, but you have to ask yourself, is it the same infection happening at the same area? Like, for instance, if you have recurrence at this specific area, like just the ear, over and over and over again, is it really immune deficiency? Because immune would be the whole system. If it were immune deficiency, you just see more ear and the nose and the throat and the respiratory and the GI and all over the place. If it's just the ear over and over again, you want to think anatomical. Is there a defect with the shape of the ear? Is there something wrong with the tympanic membrane causing increased bacteria or fungus to be in that area? So you want to make sure you understand what you're looking for. Take a step back for a second and think, is this really a sign of the immune system being down, or is it a sign that there's one specific location that's weak? So again, congenital means you're born with it, some kind of a genetic anomaly, or it can be something that's acquired. And the acquired is way more common. You get a lot more of those out there. So acquired is usually either caused by another illness, or it can be iatrogenic, like chemotherapy can do it. So remember, iatrogenic means doctor did it, but by chemotherapy, they suppress your immune system, and it makes you more susceptible to other disorders. It can be trauma, like burns. Burns suppress your immune system. It can be stress. Your lymphoid organs are controlled or have some innervation by the autonomic nervous system. So when you're stressed out, it turns down your immune system. And we just know that. You release cortisol. Cortisol is an immunosuppressant. So there's a lot of different things. Oops, for some reason can't slip. There we go. So there are kind of 10 clinical manifestations or warning signs of immune deficiencies. But when they look at it, they want to know what exactly is it. So there are a few things they do. First, they want to quantitate. So they'll look at the numbers of T cells and B cells and complements and antibodies. That's quantitative. Do you have the right number of that structure? Then they'll do a qualitative analysis. And qualitative is this, okay, so maybe you have enough T cells, but are they working? Is the quality or their performance doing it? So when they're looking at these different problems, they're going to look and break it down. T cells, B cells, complements, antibodies, phagocytes like neutrophils, macrophages, and then are they working appropriately? So we're going to go through and we're going to talk about several of those. Let's start with the primary deficiencies. So primary immune deficiencies, originally they thought they were really rare. But what they're looking at now is that they're actually more common than we originally thought. So the World Health Organization and the International Union of Immunological Societies actually list about 181 deficiency disorders That's a lot of disorders. When you look down here, you can see lots of different ones. They seem rare, but when you put them all together, there actually is many primary immunodeficiencies as there are leukemias out there. So for the number of incidents of leukemia, you have about the same incidence for primary immunodeficiencies. About 4 times as common as cystic fibrosis. If you look at the proportions, over half of them are due to bad antibodies or defective antibodies. So there's a lot of things that are going on here. Some common themes you might expect or see are that most of them are because of one single gene defect. So it's a single gene mutation or a single gene flaw. It doesn't have to be hereditary. It could be that mutation. Most common, they're actually sporadic instead of inherited. So this person is the first person in their family to have it, the proband. So you might see no history of it in their family, and then poof, this child has it. Usually they're detected by the time they're 2. So they're immune things. Think about kids and all the diseases they pick up or all the sicknesses that they get. So you're definitely going to have signs of a weak immune system early in life. Right? So they're more susceptible to infectious diseases, autoimmune, GI, etc. Another key to remember is that typically it's multiple organs in recurrent infections. So it's not just one location. It's usually different organs that are affected. There are 5 primary groups, and you can see them broken down over here. So B, T, complement, phagocyte, or combined T and B. I love this picture. You can go and look at it. This was actually a clipping out of a newspaper called The Failing Immune System, and there's more to this picture if you go to that online website, but it talks about, it's kind of a nice summary of the different immunoglobulins or antibodies. It talks about how the immune system is like this puzzle, and it's fighting off bacteria, but if you miss the puzzle piece, the bacteria can slide through, or the fungus can pass through. So it's kind of a cool article to read, and it's very lay person focused. Since we're talking about primary immunodeficiencies, there's actually a list of 10 primary warning signs, but I'm going to go through 4 of them, and you can read the rest later. In general, you see infections that respond poorly to treatment with antibiotics. So these people, you give them antibiotics, and they still don't respond very well. Because the antibiotics aren't always there to kill off everything. They're there to kind of get rid of as much as you can so that your immune system can kick in and take care of the rest. And another thing is that they usually have delayed recovery or never completely recover from the infection. So they'll get this infection and they never really get over it. Certain types of cancers. Not just certain types, but unique types like Kaposi sarcoma or non-Hodgkin's lymphoma. Things that aren't extremely common. They get these really weird diseases because remember, your immune system's attacking cancer. These strange cancers pop up. And then the last one, they have a tendency to get certain opportunistic infections. Also, usually rare infections. Like when we talked about HIV the first week, we said the first cases of HIV, these people were dying from something called pneumocystis carinii pneumoniae, or pneumonia. They were getting pneumonia from a fungus. I mean, a lot of us have this fungus in our lungs, and our immune system takes care of it. But these people, they were dying of this stuff, and they're like, wow, why are they dying? And it's because they have this weird immunodeficiency syndrome, which now we know as AIDS. So let's break these down one at a time. Remember, B's, T's, complements, phagocytes. But the B, what do B's make? What do the B lymphocytes make? They make antibodies. So when you see this, the B lymphocyte deficiencies are usually because they don't make enough of an antibody or enough antibodies in general. And here are the processes antibodies do. We've talked about these before. Antibodies, they bind to things and agglutinate. They stick them together. They opsonize or they butter the bacteria so it's more delicious to phagocytes. All kinds of different processes. When you have hypogammaglobulinemia, you have decreased immunoglobulins. So the way they treat that is they increase, they supplement you by increasing or injecting IV immunoglobulins. Agammaglobulinemia, same concept. This is a little bit more dangerous because they are completely without the the antibodies. Here's the key with B. B lymphocyte deficiencies, if you give these people a vaccine and they can't make antibodies, what do you know is going to happen to them? Are they going to be immune to this? No, they can't build an immune system to it. When you're vaccinated, what happens is that you get this chemical in you and your immune system makes antibodies and B cells to fight it, but you don't have them, so you can't fight it off. So that's kind of the key, is that they don't respond well to vaccines. It lets you know it revolves around this antibody or B cells. The next is with antibodies. The main key with antibodies is they like to stick well to things that have a strong coat, like encapsulated bacteria. So bacteria have a coating around them. We also refer to these as pyrogenic bacteria, so the bacteria that have a tendency to make you have a fever, like strep pneumoniae or staph aureus or influenza or meningitis. So Neisseria and meningitis, it causes meningitis. You see more of that. So they cause a lot of like ear, nose, throat, septicemia issues. Right? Again, if you look at these subtypes, there are about 181 different deficiency disorders, and I'm not going to spend the time going through 181. I'm going to point out the main disorder, some of the key symptoms, and then give you examples of the names. Like this. IgM, this is an interesting one. X-linked hyper IgM. Hyper, you wouldn't predict that. But what happens is, when your immune response, if you remember, your initial immune response, you make IgMs, and then those are later replaced by IgGs, which are way more powerful. Well, in this situation, they can't make the IgGs, so they keep making the IgMs that, well, frankly, suck. So you get exposed to this stuff, and the IgMs aren't as powerful as they should be, so you keep, getting bacterial infections. IgG, the more powerful, the more common, the most abundant. If you can't make those, you're more susceptible to attack by encapsulated bacteria. And then Bruton A-gamma globulinemia means that you can't make the immune cells. So there's no B cell receptor. The B cells don't talk to other cells very well. And that's the problem. So these people require regular infusions of IV Ig. So IV intravenous Ig immunoglobulins, if you didn't catch what that meant. But again, no vaccine response. They don't respond to vaccines. And this next one, common variable immune deficiency, actually has its own slide, but it's usually associated with autoimmune diseases like, and also malignancies. But here's the trick. They actually have normal B cells, but the problem is that the B cells can't communicate with other cells. So, and it's the T helper cells, the T4 or CD4 cells that they have a problem with. So they typically have low Ig because their B cells don't know there's a problem because they can't communicate with the T helpers. So usually this is more mild, and the effects actually come out around the age of 29, so adulthood. Next, T lymphocytes. A common one you'll hear about is called DeJour syndrome. DeJour is interesting because we know where it's at. There's a handful of genes on the 22nd chromosome that are missing or defective. And because all of these genes aren't just immune, they're also things like forming the pharynx, forming cardio structures, forming facial structures. You see more of these physical characteristics that come along with it. About 1 in 2,000 pregnancies actually they believe carries DeJour, but only about 1 in 4,000 births will have one in DeJour. So in other words, about 50% of these pregnancies don't actually go out to delivery. DeJour, its primary immune relationship is it's affecting the thymus gland. So the thymus gland, remember, matures T cells. You can have thymic aplasia without growth, and they call that complete DeJour, which means they have no thymus at all. So they don't make T cells. Well, they make them, but they just can't mature the T cells. So the trick is with T cells like to identify viruses, fungi, and some bacteria, where B cells really focus on those encapsulated bacteria, things that can be hit with antibodies, right? T cells, they love viruses, infected cells, fungus, certain types of bacteria that antibodies don't stick to very well, like mycobacteria, like tuberculosis or salmonella. So those kind of things. So these you see more oral infections, diarrhea, pneumonia. When you're doing a differential, remember there are some key characteristics like B and T cells, they both attack bacteria. But what would make a T cell unique? It likes to go for the viruses or the fungi or the really weird bacteria. Where a B cell is more for the encapsulated bacteria. So look for what makes this type of syndrome unique, and it stands out. Ways we classify these sometimes, by the way, you can see T negative, B positive, NK positive. It means that in this syndrome, their T cells are broken, negative on the T cells, but their B cells are healthy and their natural killer cells are healthy. So that's a way that we write that up sometimes, is they have defective T cells but good B and natural killer cells. these people were more susceptible to fungus, and this is an example of Candidus albicans. This is actually a vaginal yeast, but this is on the person's mouth, and because they have defective T cells that can't fight off fungus, they get their mouth covered in candiditis, which is a fungal infection. All right, next, combined T and B cells. So if you know T cells attack fungus and virus and some bacteria, B cells like to attack encapsulated virus. What if they keep getting encapsulated bacteria and they get virus infections? Look at combined. You know, it doesn't have to be one or the other. It can be a problem with both. And these are severe, and that's why they call them severe combined immunodeficiency. So, SCID. About 50% of SCIDs are X-linked. The most dangerous one is actually called reticular dysgenesis. This is T minus, B minus, NK minus. What's that telling you? The T cells, the B cells, and the NK cells, they're all defective. Their immune system is just shot. So their immune cells are basically just dead in the water and not doing anything. Most of these cases actually fail to develop. So most of them won't even be born. They can't survive. When you look, the pathways are usually what's going on. So when you look at a cell at the surface, you've got all these interleukin receptors. Most of these are actually interleukin receptor problems, like X-linked SCID, the most common form, interleukin receptor defect. When you look at IL-7 receptor defect, sometimes it's the second messengers, like JAK3. And sometimes it's an enzyme, like adenosine deaminase deficiency. So, lots of different things. Oh, sorry. Actually, forgot to point out, this is the bubble boy. So when you hear about SCID, you usually hear the bubble boy. And the tragedy with this kid is that he was in the bubble for a long time, about the age of 12. He got a transplant from his sister. Unfortunately, the tests weren't very good for viruses, and his sister had Epstein-Barr virus, which causes mono. So he was given bone marrow from her, and the virus actually took his life. Okay. So some more forms of SCID. In general, just look at all the problems that could possibly happen. Like RAG. Remember when you're making the T cells, you have that random association or random combination generation? Well, what if you can't do random combinations? There's a lot of stuff out there that you wouldn't even know exists, so they get into you and they attack you and they kill you. Bare lymphocyte means there's no MHCs on the surface. These, most children that have them actually die before the age of 5, because if there's no MHCs, there's absolutely no intracellular cooperation. The cells can't talk to each other. They don't even recognize their neighbors. They don't even know what's going on. They're just wandering around deaf, blind, and without feeling, basically. They're just there, but doing nothing. And the main point with these pictures is to look at all of these different communication structures. Any of these forms of SCID can affect any of those. So it could be the T cell receptors, it could be the MHCs, it can be a CD4 receptor, CD40, it can be an interleukin receptors. It can even be antigen binding. It can be the MHCs over on the macrophage. It can be any of these things at all. If any of them are broken, poof, suddenly you have SCID. Right? This last one here, I'm going to have you look up. So this is a form of SCID. It's called Wiskott-Aldrich syndrome. Right? It's X-linked. They have increased IgM, right? And it also increases the risk of autoimmune disorders. Your job is you're going to look it up, whether it's in the book or it's online. Make sure you cite your references. Look up Wiskott-Aldrich syndrome, and then what's its etiology? So speak from your genetic knowledge. How is it passed down generation to generation? What cells are most involved with this? And what are the symptoms related to those cells? So I want you to kind of think of the pathogenesis. What's going on? What cells are involved? What do those cells normally do? And then do the symptoms make sense to you? Pause. Come back when you're ready. All right, and then complement deficiencies. So complement, you know this. And I'm pointing out right away, complement and antibodies, they do very similar things. They like to go to the invader, they stick to the invader, and a lot of times they'll opsonize the invader. They butter the invader, make it delicious for macrophage or phagocytes to eat, right? So another thing that these complement do is they make that membrane attack complex. But the key is, remember, how many pathways are there of complement? There are 3. So there are 3 complement pathways. They all merge at C3. And that's why C3 deficiency is the most severe, is because if you lose C3, you lose all 3 complement pathways. Another common one, C5 or C9. So C9 makes the membrane attack complex. If you turn all the systems on here, but then you lose that spiky pin, it's worthless. So there can be lots of problems. What you want to think or put down here is that often complement deficiencies result in blood-borne infections. So bacteremia, meningitis, both of these are encapsulated bacteria, but they get deep into your blood or in your brain tissue and cause problems, right? So those are just some of the keys. Next, phagocytic deficiencies. So the phagocytes, the two phagocytes are macrophage and neutrophils. The key with this one, where they hang out, macrophage and neutrophils like to sit right along epithelial lining. So they like to sit in the connective tissue just underneath the skin, whether it's the skin inside the, well, I shouldn't say skin in the lungs, the lining of the lungs, the lining of the GI tract, the skin on the outside of your body. That's where they like to hang out. So there are a couple things that could be wrong here. There are three groups of phagocytic deficiencies. The first group is inadequate opsonization. So if they don't recognize the opsin, maybe the antibody sticks to the invader, so the antibody is stuck all over the invader, but this phagocyte doesn't recognize it. That's one problem. Second is maybe there's not enough numbers. Maybe you're not making enough neutrophils. Maybe you're not making enough macrophages, right? And the third is defective activity. So the activity we've talked about before. These cells are circulating, and then they smell an invader. They pop out these adhesion molecules. They pavement along here, slowing down, margination. And then they move into the tissue. So maybe they don't pop out these adhesion molecules, the CAMs, cellular adhesion molecules, or integrins. Maybe they can't smell the invader. Maybe they don't have the appropriate receptors for complement. Maybe they don't have the appropriate enzymes inside of them to break things down. Like, for instance, in here you have that myeloperoxidase that breaks things down. It could be superoxidase, a reactive oxygen species. It doesn't matter. You have these enzymes inside the lysosome, lysosome, that break apart bacteria. Let's say they eat the bacteria, but they don't have any good enzymes in the lysosome. It's like you not able to digest your food because your stomach's not acidic enough. Right? So there are lots of problems that can happen. And again, here are some names of deficiencies, but in general you want to pay attention to the main groups: adhesion molecules, receptors, the enzymes on the inside. Maybe you don't make enough, so neutropenia, right? Not enough neutrophils, or maybe it's just inefficient opsonization. So another problem that's common is called chronic granulomatous disease, which means that they make these granulomas full of these phagocytes, but they're worthless. So remember, a granuloma is where you have an infection and you block it off, but your immune cells can't attack it, so they just hang out there doing nothing. Right? So about 2/3 of these are X-linked. The phagocytes can't make a reactive oxygen species, so the enzymes in here, whether it's superoxidized, whether it's hydrogen peroxide, doesn't matter, whether it's myeloperoxide, any of those different things. If you can't make the enzymes to digest, you can't break down the bacteria. Right? They're most susceptible to bacteria that are called catalase positive. So catalase positive are like Staph aureus. And Staph aureus, it's an aerobic bacteria. When you dump hydrogen peroxide on it, it will actually bubble all gassy because it reacts with that with that catalase. So you can't make the enzymes to break it apart. So your cells start dying. I already talked about adhesion molecules, and then toll-like receptors, the ancient messengers. If those toll-like receptors are broken, they can't recognize bacteria. They can't recognize the PAMPs on the bacteria. Right? So you're more susceptible to invasion. Here's kind of a review. Definitely go back through and look at the key points, not just in this section, but the last section. We talked about neutrophils and eosinophils and basophils and what they do. So if you have a decreased basophil number, what are you going to be more susceptible to? Allergic stimuli. If you have decreased eosinophils, you're more susceptible to parasites. So hopefully if you understand what the players are there to do, if they're missing, that's a weakness in your defense. So it's kind of like watching a football game or a chess game. Each chess piece has a certain skill that it does. It can move in a certain fashion. If you lose it, no other players can move in that way. So they're exactly the same. Here you see some of the different things. So just kind of as a review, antibody deficiencies, antibodies attack encapsulated bacteria. So does complement. So if you have a decreased antibody, you get more pulmonary infections, you get more mycoplasma infections, which we'll talk about in the infection system. But mycoplasms like tuberculosis, macrophage can't eat tuberculosis. They depend on antibodies to stick them down, right? Parasites like Giardia. Giardia is in your GI tract, and here's actually a picture of Giardia. It causes really bad diarrhea and toxic levels. It can actually get into your bloodstream, so it's dangerous. Antibodies stick to these, and they help your body clear it. When you're looking at complement, remember, complement does similar things. So complement likes to stick to encapsulated bacteria, but it also likes to stick to bacteria that cause meningitis or septicemia, kind of the deep bacteria, right? B cells and T cells. B cells for encapsulated bacteria. If you're wondering what's the difference, well, what's the difference between an antibody and a B cell? Well, B cells make the antibodies, and then you can actually look. You can do a quantitative and qualitative analysis. Do they have enough B cells? Well, if they do, are they making enough antibodies? If they have enough antibodies, are they doing what they're supposed to be doing? So you can test to see how effective they are. T cells are primarily for virus, fungus, and unique bacteria. So mycobacteria. You might be thinking, what's the difference between an antibody and a T cell? Well, run a serum test, and it'll help you differentiate. Phagocytes, they like staph infections, they like salmonella, they like fungus. So if you have a higher risk of fungus, you might want to look at a T cell or a macrophage. It's a process of elimination. You look and you knock out what two things, could it possibly be, and then you try and prove one of them, well, it can't be this one because of whatever. The one left standing is your most likely cause. So make a game out of it. Kind of play around with it. Right. So next we're going to talk about secondary deficiencies, things like HIV. So secondary deficiencies, the key is they're acquired deficiencies. They're way more common than the primary immune deficiencies. So remember, primaries, congenital, secondary is acquired. The three most susceptible people to secondary infections are pregnancy, newborn, and age, because all three of them have a decreased immune system. While mom's pregnancy, while the baby's in there, her immune system slows down so that she doesn't hurt the baby, which makes her more susceptible to other things. Newborns, mom's been protecting them since they were conceived. Their immune systems suck. Right? And in the age, they're older, their thymus gland's getting smaller, their T cells don't work appropriately, and they're at more risk. So all three of those people are at higher risk. When you hear about E. coli infections that make people deathly ill or even kill people, it's usually pregnant, babies, or elderly that are being affected. Right? Secondary deficiency causes can be stress. Remember, stress affects your lymphoid system and it turns it down. It's called psychoneuroimmunology. So your immune system has a huge impact. It could be diet. Your T and B cells need things like zinc, vitamin A, vitamin E, vitamin B. You need those. If you don't have those, you can't make efficient T and B cells. It could be medical. So things like immunosuppressive drugs, surgery. It could be trauma, like burns. Already talked about that. So there are a lot of different possibilities. And then, of course, now we're down to AIDS. Right? So AIDS and HIV. HIV causes AIDS, but AIDS is not absolutely HIV. AIDS is telling you that your immune system is at a very low level. Right? HIV is telling you that you have a presence of a virus. When you look at the infection rates, we've got about 5 million per year, about 31,000 here in the United States. The cell it affects is a T helper cell. That's the major communicator between all of the immune cells. You shut this down, it's like the T helper cell is the president. It's like taking the president out of his leadership position. The president is the commander-in-chief of all of the branches of the military. You remove these, and there's nothing telling all the branches how to work together. They become very disrupted. They don't work appropriately. They can't respond appropriately. So what happens is HIV gets inside these cells and causes them to die, lyse, and I'll show you how. And then when you look at how it's transferred, it's bloodborne, sexually transmitted. More women are getting it than men. It used to be the other way around. Infants can get it too. About 3/4 of infants that have a mother that has HIV, they get it too. It can be because HIV is small enough to cross the placenta. They can get it during delivery when there's an exchange of bloods, or they can even get it during breastfeeding. And that's crazy because if the baby already has HIV and you breastfeed it, you're just putting more HIV into it and you're increasing how many cells are being affected, so it's not a good idea. Right, so acquired immunodeficiency syndrome, that's AIDS. The pathogenesis is it starts as HIV, a retrovirus. Retrovirus means it starts as an RNA, injects into your cell, and it turns into DNA before it gets into your nucleus and into your own DNA. So you need something. To turn it from RNA to DNA, it needs something called reverse transcriptase. And that reverse transcriptase turns the RNA to DNA and lets it inject. Integrase actually helps like copy and paste it, or cut your DNA and paste its virus DNA in. That's integrase. I'm pointing these out because the treatments for it target these things. It tries to stop reverse transcriptase so it can't write the RNA to DNA. It tries to stop integrase so that it can't actually integrate into your cell's DNA. So here's the big picture. You can look at the process. The next several slides actually go through the process. I'm going to just do it right here and save us a little bit of time, but here you can see the HIV virus. You've got these little things called GP120s on the surface, and they're little glycoproteins. They're covered in sugar, which camouflage them from your cells. But when they get close to a CD4 cell, they kind of peel back the sugar. They bind their GP120 to your CD4 receptor on a T helper cell. When it binds, it opens up the membrane and it injects its RNA inside of you. So you have this, basically this entrance process. So if you could stop it here, you'd prevent HIV from spreading. Once that RNA is in here, it uses reverse transcriptase to turn it into DNA. Treatments focus on stopping this reverse transcriptase, because if it can't turn to DNA, it can't inject into your nucleus. The next, this DNA cuts and pastes itself into your DNA by something called integrase. So if we give you an integrase inhibitor, hopefully it stops that. So you can see lots of different steps already getting right down here into the DNA. Once it's in here, it can turn on genes and just keep replicating, making batch after batch after batch. When those batches are ready, they can go in, be encapsulated, and inject, and go on to move on to another cell. So, or it can just fill up with hundreds of thousands of these little viruses, and then when it pops or bursts, it releases them all into your body. So bad news all the way around. And like I said, I already talked about this. The part I haven't talked about are the CD4 counts. So normally your CD4 count should be about 800 to 1,000 cells per cubic millimeter. And a millimeter is about the thickness of a dime. So if a dime's laying flat on the table, it's about 1 millimeter tall. Imagine that being cubed. 1 millimeter deep, 1 millimeter tall, 1 millimeter wide. So there are about 800 to 1,000 of those little CD helper cells, or CD4 cells in there. When they talk about reversing the ratio, normally you have about 800 to 1,000 T helper cells, but you have about 400 to 1,000 of the CD8 cells. Normally it's a 2-to-1 ratio. 2 T helpers for every cytotoxic. Right? When this reverses, and there are about 2 cytotoxics to every T helper, then it's a sign you might have HIV or at least some immunosuppressive problem. If you have really high T helpers, so super high T helper cells, it may just be a sign that you have a bad infection or a viral infection or maybe even a blood-borne cancer. So there are a lot of signs. It's not just that if you have low white blood counts, then definitely have HIV or AIDS. But there is a number. When your cell count, your T helper cell count drops below 200, then you have what we call AIDS, and it takes about 10 years for you to get to that stage. How we test for this, we can do it 2 ways. We take a blood serum test, so we can take some of your blood. We do an ELISA test where they'll take this little well and they'll put HIV along the walls of the cell, of the well, just the antigen, so not actually infective HIV, but they'll take the antigen and line it. They take your blood. If you've had experience to HIV, now you have antibodies. They dump your antibodies in this well. If your antibodies attack the HIV in the wall, they know you have HIV in your body because your body recognizes it. So it's a really cool process. We used to do this in the lab almost every day. But they can do it for things like HIV. It's a really sensitive test, so it's usually pretty accurate. Here's kind of a trick. So if you get a positive test that says it looks like you have HIV on this, they'll do a second test, something called a Western blot. In this situation, instead of looking at the antibodies, they'll actually pull your blood out, they'll separate the cells, and they'll shatter the cells. They're looking for the structures in HIV. So they're looking for those GP120s, they're looking for reverse transcriptase, unique characteristics that identify this disease. Then they put in a little thing called an agarose gel and they run it. So by its electrical current, it'll separate by size. You can see like the GP120s will go here, the GP41s, the reverse transcriptase, blah, blah, blah. So they know this is what HIV looks like on this blot. All these lines separate. They'll run your samples, and if they see that the samples look just the same, then they know that you have HIV in your body. Right? Here's the last kicker. When you're testing for it, antibody serum tests usually take 2 to 8 weeks to show up. So in other words, if you got it by blood-borne, somebody injected with a needle, you got a blood transfusion, your blood brothers and swapping blood with a cut handshake, whatever. If it's blood-to-blood transmission, usually it shows up within 2 to 8 weeks, usually around 28 days on average, right? But if it's by sexual contact, it can take 6 to 14 months for it to show up on a blood test or any test. So that's not to say you can't spread it. Within 2 weeks, you're contagious. So whether you get it from sex or injection, within 2 weeks, you can spread this disease. But it usually takes 2 to 8 weeks for it to show up by blood-borne, or 6 to 14 months to show up if you got it through sex. So because of this, we actually believe that about 100 people are infected for every one person diagnosed with HIV. Yeah. Right. So the window period's what's referred to as the time that you're infected with it until the time that it shows up positive on an HIV test. So when you look at the progression, it starts off as being serologically negative. Even though you got it in your body, it looks like you don't have it. And then about 2 to 8 weeks later, you start showing up as serologically positive, but you're asymptomatic, so you're not sick. And then in early stages of HIV, you'll start seeing flu-like symptoms, recurrent illnesses, unusual illnesses, and then about 10 years in, you actually get AIDS. And AIDS is defined as having a white blood cell count, a T helper cell count of under 200 cells per cubic millimeter. So really about 20% of a normal count. Really, really low. And here you can see the T helper cells. T helper cells start dropping right away as HIV goes up, and then you start kind of regulating HIV. But your T helper cells are growing lower and lower and lower. And then about 10 years down the road, you can see the HIV is dramatically increasing because the immune system is dramatically decreasing. Did I cover everything on here? Yeah, I did. And then Kaposi sarcoma. So here's one of those things that come along with HIV. Kaposi sarcoma, it's actually the human herpes virus 8. Human herpes because it's no other animal vector. It's only exclusively a human disorder. And Kaposi sarcoma is not selective to HIV. It's just looking for immunocompromised people. HIV just seems to be an easy target. So if you're immunocompromised for any other reason, you still are susceptible to it. Kaposi sarcoma is actually cancer. You can see all these little endothelial cells. They're proliferative. They grow abnormally, and you have this basically outpouching of a blood vessel. So we call these little macules. They're raised lesions, and if you push on them, they don't blanch. They don't turn white. You let go of them, they're still dark, and they're painful. They're prone to ulcerations, so they can pop. Right. And then, how do you treat HIV? Heart's highly active antiretroviral therapy. It's actually more than one drug. It's about 3 or 4 drugs. They're trying to stop these different steps of HIV spread. So you can see here, interest inhibitors, reverse transcriptase inhibitors, integrase inhibitors, protease inhibitors. It's trying to stop it through here. FDA has actually said that AIDS has dropped. So it used to be considered one of the causes, or the top 10 causes of death in the United States, but it's actually dropped out of that ranking. So it went from being like 42,000 people in 1994 that died of AIDS down to 17,000 in 1997, just 3 years later. So dramatic difference. Heart is not a cure. Heart just postpones the progression of the disease. So once the disease is in your body, you can't remove it. There's no way to get rid of it. And then the biggest problem is the HIV. We can't make a vaccine because it mutates so fast. Just like the flu. Every year when you get a flu shot, it's the same old flu. It's just mutated enough. So they give you all these different, chemicals that they predict will be the flu virus this year. HIV changes way too fast, so it's even hard for us to predict it. So let's see if you remember this or get it. So do you know, what's the name of the cell and the receptor that HIV has an affinity for? I'm really hoping you said the CD4 cell, CD4 receptor on the T helper cell. All right. Next graft versus host disease. This happens to people that are immunocompromised. You get a transplant. This is the sequence. So they need a transplant. You give them tissue. If their immune system is compromised, and you give them healthy tissue that has immune system in it. So Bob is a recipient, but Tom is a donor. When Tom gives Bob this organ, Tom's blood cells, white blood cells like T cells, may still be in it. When that organ goes into Bob's body, now suddenly Bob's body goes, this thing's an invader, and it starts releasing cytokines. Well, those cytokines start stimulating the T cells that came with the organ, and those T cells go crazy and they start attacking the recipient. And they could potentially kill the recipient. It's called graft versus host disease. So it only happens to people that are immunocompromised because their own immune system's not strong enough to fight off that new immune system. Typically, you see it attack the skin, the liver, and the gut. And they evaluate its progression based on if it's on the skin, what percentage of the body surface is covered. If it's in the liver, they rate how much bilirubin you make. So if your liver's being damaged, your bilirubin count goes up. And then in the gut, they actually have you measure your stools, making sure it's coming out okay, making sure it's not too watery, not too thick, and just the right texture. Yummy. Right. When we refer to it as acute versus chronic, acute just means that you start getting all of these symptoms within the first 100 days. Chronic means it took a while to kick in, but now you're getting the problem. Right. And the last, the treatments. And I'm actually going to have you do some of the homework on the treatments, but the first thing is evaluating it. You can do complete blood counts with the differential so you can look for what kind of eosinophils, what kind of basophils, all of these. So you can differentiate. And you already know, if you have too many basophils, what's the problem? There's probably some kind of allergic reaction, right? If you have too many eosinophils, probably parasitic issues. Next, they're going to look at the immunoglobulins. Do you have enough IgAs, IgGs, IgM, IgE, IgD? You already know all these different things. And then qualitatively look at them. So maybe you have enough of each of these, but are they doing their job? So we can use that ELISA for determining the presence of these things. And then skin test. TB is the one you're going to think of. Put a little injection of whatever it is underneath the skin. If your body's seen it before, it will attack it like crazy and cause this thing called a wheel and flare. So red swollen bump with this red area around the outside. This is incredible. This is the future. So gamma globulin replacement therapy, not so much the future yet, but if they're deficient in IgGs, you give them IgGs, right? So it's called IVIG. You know what IVIG means. I've said it several times, but you just inject them with immunoglobulins. The immunoglobulins are only good for about 3 to 4 weeks, so they have to have complete, repetitive injections. So another option is transplants or transfusions. Giving that kid some bone marrow, some healthy bone marrow. So what they have to do is they have to get rid of all of its old defective bone marrow and give it brand new ones so that the two bone marrows don't fight against each other. And then this is incredible, gene therapy, where they can actually take the defective gene, if you're not making the appropriate enzyme, take the gene, put it in a virus that does not cause harm anymore. You grow it on a dish, and then you put it right in that kid's blood, like this. So you can give an IV right into their blood, and then it starts injecting the virus DNA with the good gene into all that kid's cells. So hopefully it goes to all the cells in the body. Now it has the gene. You can actually do it in inhaler form too. The problem is, as soon as your body recognizes the virus, what's going to happen? It's going to start making immunoglobulins, antibodies against it. And then the problem there is that now you can't use that same virus more than once because now the body's way ready for it and it's going to kill it right away. So, do you know what type of person is most susceptible to graft versus host disease? And I'm really hoping you said immunocompromised. Last question. I really want you to try and make this stuff your own. Make it layperson's terms so that you can just talk to other people about it. It's the best way to learn. Share the cool stuff. So imagine you're sitting on the couch watching Bubble Boy. It's a movie from the 1970s that had John Travolta as the kid in the bubble. Right? This friend you're sitting with is non-medical. In layperson's terms, you can Google this stuff. You need to tell them in layperson's terms what's wrong with the SCID patient. So what's wrong with the Bubble Boy? How do we prevent them from getting infections if they don't have an immune system? Explain ADA enzyme therapy. So I want you to look that one up. I didn't actually talk about it, but I want you to look it up and explain how it works. Layperson's terms. Explain gene therapy. I kind of went through it and gave you a layperson's rundown, but I want you to be able to explain it to people too. So when someone says, "What do you know about this gene therapy stuff?" he's going to answer it. And then, what's the only known cure for SCID? There's only one known cure for it. What is it? So here's a nice link down at the bottom that might get you started on some of these. It's not all the answers, but it will answer a couple of them for you. All right, we'll see you on the next videos.